చేశాను ఆల్రెడీ ఓపెన్ పెట్టాను. వస్తుందా? Good morning everyone. I am replacing today for Dr. Abhishek. So he was dealing endocrinology for you. He will be not available this week, so this class I am taking today. I will be talking about viral hepatitis. So as it is an important topic for all undergraduates, I am talking about viral hepatitis today. Next week Abhishek will be taking your class again. Okay, so in viral hepatitis, the most important, there are two kinds of viruses, but are hepatotropic and non-hepatotropic viruses. Hepatotropic viruses are hepatitis virus A, B, C, D and E. There are other non-hepatotropic viruses that also infect the liver, like CMV, Epstein-Barr virus, HIV. Almost all viruses can infect the virus, but these viruses specifically infect the liver, A, B, C, D and E. So we will be talking about the clinical features and different epidemiological features, treatment of hepatitis A and B today. Okay, so just a minute. Yeah. Okay. So hepatitis results from various etiologies. It can be infectious, that is viral, bacterial, fungal and parasitic agents, and also non-infectious, that is maybe because of toxic injury or autoimmune hepatitis or metabolic diseases like alpha-1 antitrypsin deficiency or hemochromatosis, Wilson's, all these metabolic disorders, and also because of ischemic injury. Okay, so hepatitis can be both infectious and non-infectious. In this topic we are talking about viral hepatitis. Viral hepatitis is mostly common by A, B, C viruses. D and E are also common, but not as much as these viruses. So as I already told you, cytomegalovirus, Epstein-Barr and herpes simplex can also infect the liver, but they don't specifically infect the liver. They are not called hepatotropic viruses. Not called hepatotropic viruses. So coming to hepatitis A virus, see, it's a non-enveloped RNA virus. It belongs to the family picornavirus. The main mode is transmission is through fecal-oral route. Like other diarrheal diseases, this is also through fecal-oral route. It usually infects the families and communities in the locality. So clinical features. So almost all hepatitis, viral hepatitis, present with a common clinical feature, that is they'll have a viral prodrome. Prodrome is like fever, malaise, joint. Maybe they have joint pain, anorexia, nausea for few days, for a week. And by the end of the week, when the fever is subsiding, they start developing jaundice. Jaundice doesn't start with the fever. Jaundice appears after the fever. Within 5 days, after 5 days or 6 days of fever, the person will start having jaundice. If jaundice and fever start appearing together, then it is not viral hepatitis. Okay. So clinical feature, this pertains to all viral hepatitis, and specifically here we'll see. Okay, in hepatitis A virus, it is asymptomatic in most of the cases and anicteric to several weeks. Okay, in most of the cases it may be anicteric because it's mostly diarrheal disease, but in some patients it will also develop jaundice. Asymptomatic and anicteric to several weeks of malaise, anorexia, nausea, vomiting and elevated transmission with or without jaundice. Jaundice is not a prerequisite for diagnosing hepatitis A. It presents as a diarrheal disease in most of the patients. So prognosis, hepatitis virus doesn't have any chronic state. It's usually self-limited. It will go down within a week or two in most of the patients. Okay. Treatment is generally supportive management, and prevention is through hand hygiene and improving the socio-economic status of the locality. It usually occurs in poor localities. Post-exposure prophylaxis. This prophylaxis is not given in India. This is only in abroad. This is for theoretical purpose only. In India, where we don't give any post-exposure prophylaxis or any vaccine as such. It is only given in high-risk patients, people whose liver is already damaged because of some other cause, like hepatitis B, C, or some other alcoholic cirrhosis, some cause of cirrhosis. If the liver is already bad, in that patients we may give hepatitis A vaccine in India. Otherwise, we don't give hepatitis A vaccine in India. So it is straightforward. It is usually a self-limited disease, and treatment is through supportive management. Vaccine is only given in high-risk patients. Okay. The most important topic we come to today is hepatitis B. Hepatitis B is a DNA virus. Unlike RNA virus, DNA viruses cannot be eliminated easily. A DNA virus infection, the DNA goes and binds with the human DNA, and it is very, very difficult to treat them. You cannot treat them; they stay forever. Okay, and they'll have periodic reactivations. So DNA, that is the problem with DNA virus. It belongs to the family Hepatitis virus. It is a double-stranded DNA virus, and one strand of it is not complete. It is an incomplete double-stranded DNA virus. There is a circular DNA. One strand is complete, the other strand is only partial. It is not completed. The ring is not completed. Okay. Mode of transmission. It is mostly through parental, sexual, and perinatal exposure. The risk of HBV transmission is very, very high compared to HIV. Sexual and parental transmission, if you say it is 0.3% for HIV, for hepatitis B virus it comes up to 30 to 50% actually. It is highly infectious. Mostly medical personnel are at risk of contracting the virus through needle stick injury, and parental and perinatal exposure is very, very common also in normal population. So there are 8 genotypes, A through B. B and C are more common in Asia. That is the important thing for us. So in the rest of the world, the other genotypes are common. Okay. But knowing the genotype of HBV is not necessary, because the treatment doesn't differ between the genotypes in hepatitis B virus. The genotypes determine the treatment in hepatitis C, but not hepatitis B. Okay. So clinical features. The incubation period usually lasts from 40 to 150 days. As I have said already, the prodrome is fever, fatigue, anorexia, nausea, and malaise. This can last for 1 week. Okay, 1 to 2 weeks. After 2 weeks, patient will start having jaundice, hepatosplenomegaly, pruritus, and intense fatigue. That usually lasts for 1 to 2 months in an acute setting. If it is acute hepatitis B, it will last for 1 to 2 months, or if it is chronic, it will last beyond that. Okay, the most important point here is fever followed by jaundice, not fever with jaundice. Just a minute. That is acute hepatitis B. In chronic hepatitis B, the jaundice lasts beyond 6 weeks. Chronic hepatitis B can range from asymptomatic to symptomatic. If it is asymptomatic, it is subclinical. You do not have jaundice or any symptoms clinically, but there will be chronic hepatitis going on, the ongoing inflammation of the liver, and it will result in cirrhosis at the end. Whereas in symptomatic hepatitis, it will present with jaundice and it keeps on going. There will be elevated. So chronic hepatitis B, there are different phases. We will talk about chronic hepatitis B in a bit. Okay. So what is the risk of acute infection becoming chronic infection? There is an acute hepatitis B. The patient comes to you with acute hepatitis and he wants to know what is the risk of him becoming chronic hepatitis B. So it differs. It differs in different kinds of population. In adults, if the patient has acute hepatitis B, the chance of going into chronic hepatitis is 5%. It's less than 5% actually. Whereas in infants and children, if there is acute hepatitis, 30% of them will proceed to chronic hepatitis because the immunity is not mature and it cannot eliminate the virus. In adults, only 5% go to chronicity. In children, it's more than 30%. Okay. So this is about the epidemiology. The manifestations, clinical manifestations, like I have said, fever, anorexia, nausea, the viral prodrome followed by jaundice. And there are extrahepatic manifestations also. That is migratory arthritis, angioedema, maculopapular urticarial rash, glomerulonephritis, and papilloacrodermatitis. All these are immune complex diseases. Okay, some are caused by virus and antigen antibody reaction. Most of them, like glomerulonephritis, there is actually no virus. The antigen antibody complex that forms in the blood is deposited in the liver or skin, or in the joint, causing arthritis, glomerulonephritis, etc. So confirmation of HBV infection is through serological assays. So here is the natural history. So acute hepatitis B infection, if it occurs in an adult, here 95% of them infection is resolved, whereas in 5% of adult infections end up in chronic infection. Okay, if it is in early childhood, 50 to 80% are resolved, and 20 to 50% result in chronic infection. If the infection is acquired perinatally, 90% go into chronic infection and only 10% resolve. So what happens after this? What happens to a chronic infection and an acute infection? We will be seeing. I will come back to this slide later. Okay, again I need to show you this. So see, here is the acute hepatitis B serological course. So here I need to tell you some basics, like what is HBsAg, what is HBeAg, what is HBV DNA. So the virion, hepatitis B virion, as an envelope. On the envelope there is a surface antigen. Surface antigen, it is exposed to the outside surface. That's called HBsAg. That helps in attachment to the virus to host hepatitis liver cell and infection. Okay, the surface protein helps in attachment. That is hepatitis HBs antigen. Okay, there are two more antigens. One is HBeAg and one more HBcAg. Okay, hepatitis B, we cannot call it HBcAg. I'll tell you why. There is hepatitis B antigen. There is one core protein C, and there is one pre-core protein, that is HBe. Core protein and pre-core protein, HBc and HBe. Whereas HBeAg, E is released into the blood, and hence you call it hepatitis B antigen. Core protein is not released into the blood. There is nothing called HBc in the blood, HBcAg in the blood, because it is not released into the blood. It is only present inside the liver cell. Okay. So when hepatitis, what is the relevance of these? A core protein or pre-core protein tells you that the virus is actively replicating, whereas hepatitis B, hepatitis surface antigen, HBsAg, doesn't tell you anything. It only tells you that the person is infected. Whether the virus is replicating or not replicating will not be told to you by surface antigen. HBsAg only tells you that the person is infected. But the core or pre-core antigens tell you that the virus is actively replicating within the liver cell. That is HBeAg. And HBc will be never released into the blood. Okay, so you will not have a HBcAg in the blood. And now you need to know there will be antibodies to these antigens, because your immunity actively recognizes these antigens. There will be antibodies within the blood. So hepatitis B surface antigen is there, and hence you will have an anti-HBsAg. But until the surface antigen is in high quantity in the blood, you will not be able to detect antibody, because whatever antibody is produced will be bound to surface antigen and cannot be detected. Only when there is free antibody within the blood, you can detect it, like anti-HBsAg, like this. This is anti-HBs. Only when there is free anti-HBs, that means when there is excess of antibody when compared to antigen, so this antibody will not be bound because it is in excess. That can be detected at any time. So when there is antigen present in the blood, you will not be able to detect the antibody. Only when the quantity is different, you will be able to detect each of these. So initially what happens? So now, when do the symptoms arise? Why this 1 week of fever followed by jaundice? So what happens is, these antibodies and cell-mediated immunity detect the virus, and when they start detecting the virus, and when the immunity starts attacking the virus, collaterally your liver cells will also be damaged. The immunity damages the liver cells also along with the virus, and that is when you start having the jaundice. Okay, so here see, initially post-infection, hepatitis B surface antigen will be releasing into the blood. It will reach a peak by 12 weeks. After that, the hepatitis B surface antigen keeps on decreasing because there will be increasing antibody in the blood, but as such your antibody will not be detected yet because you need to have free antibody, more antibody than antigen. At this point still the antigen is more than antibody and you will not be able to detect any antibody at that point. So slowly the antigen titer comes down because of your immunity actively working, and after that your antigen totally comes down, and 2 weeks later or few weeks later you will start detecting the anti-HBs inside the blood. Okay, at this point you are cured of hepatitis B. When you detect anti-HBs, you are cured of hepatitis B. So coming to HBeAg and anti-HBe. So HBeAg and anti-HBe correlate with the symptoms. Okay, HBeAg initially will be high, telling you that there is high active viral replication inside the body, and after that anti-HBe appears just like anti-HBs. Okay, during this symptom, when there is antigen antibody reactions occurring within the blood, you will have symptoms. So coming to next, core antigen. Core antigen will not be released into the blood at any point. HBC will not be released into the blood. So as soon as the person gets infected, anti-HBC will be detectable in the blood because whatever antibody is produced will not be neutralized or bound to anti-HBC. So whatever antibody is produced will be free in the blood because core antigen will never be released into the blood. So you can immediately detect the core antigen. So here you can see that this yellow line is anti-HBC. Okay, immediately at around 6 weeks you can start detecting the anti-HBC. As soon as the immunity recognizes the virus, you can start detecting the IgM anti-HBC. So you can tell here the first antigen to be detected is HBsAg, and the first antibody detected is anti-HBC IgM. So this plays an important role in your diagnosis of the patient. So for example, think of a patient like this. The person has been having jaundice for 2 weeks, but he presented to you at around 3 weeks, around 24 weeks. Okay, this person had jaundice previously. He came to you but with some constitutional symptoms, but right now you detect at this point, see this here, you say check for HBsAg, it will be negative. You check for anti-HBs, it will be negative. You will think that the person has never been infected with hepatitis, but no, the patient had jaundice for some 4 weeks, 5 weeks and came to you with anorexia, nausea and some symptoms like that. So if you detect at this point, the patient will have IgM anti-HBC. Just a minute, excuse me. So that's it here. See, that is the relevance of IgM anti-HBC. This is called the window period where you will not be able to find either HBsAg or anti-HBs, and you can detect anti-HBC in that window. Okay, this is the window. I think you are getting it. You can let me know in the comments if you don't understand or you want me to go slow. Okay, looks like you're not having any doubts. Fine, I'll go ahead. So this is it. See, in the early acute phase, the hepatitis surface antigen is positive. That means the patient is already infected. HBeAg, that means the virus is actively replicating inside. And IgM core, I told you, because the core antigen is never released into the blood, and hence the antibody will immediately be positive. This is acute hepatitis B. When the patient has recovered, like here, the patient has recovered, the symptoms have gone at this point. Okay, when the patient has recovered, what happens? Surface antigen is negative, virus is eliminated. Hepatitis B antigen is negative because it's not replicating. Core IgM will not be positive because IgG will become positive at this point. Initially IgM will be positive, and now the IgG becomes positive. Okay, after the acute phase is over. And hepatitis B antibody is positive, hepatitis E antibody is positive, hepatitis B DNA will not be detectable. It may be detectable if it is very low, but it will not be detectable. That is how an acute hepatitis B progresses. In adults, 95% go through this phase. In children or in perinatal infection, only 10% will be cured this way. So what happens to the rest? The rest end up in chronic hepatitis B. So chronic hepatitis B will have different phases depending upon what age you are, what age the patient is, and what age the patient has got infected. So it will differ. When you are an adult, only 5% go into chronicity, that we have seen. But what happens once you go into chronic phase? Which phase you will enter? So the different phases for chronic hepatitis B. One is immune tolerance phase, immune clearance phase, inactive carrier phase, reactivation phase, and resolved hepatitis. These are the 5 phases. It doesn't mean that each person should go through all of these phases. It depends upon what age you are infected and the immune status of the patient also. First we will understand what each of these phases mean, and then we will see which patient goes into which phase. Okay, fine. I'll keep checking the comments just in case you ask any doubt. Okay, if you have any doubt or if you want me to go slow or tell me something, stress on something, I'll be able to tell you, right? Okay, so immune tolerance phase. So what is this phase? This is mostly seen in perinatal infection or early childhood infection. What happens is the immunity will not be thinking of hepatitis B virus as some infection. It will be thinking that this is something that you are, some infection that you, this is something that is within the body itself. It will not recognize hepatitis B virus as a foreign antigen. So what happens? The virus happily replicates within the liver. That's called immune tolerance. The body will tolerate the virus. So what will be positive in these patients? Like I said, hepatitis surface antigen will be anyway positive because the person is infected. Hepatitis B antigen, which tells you that the virus is actively replicating, is also positive. Because the virus is not recognizing the antigen at this point, the body is not recognizing the virus at this point and is not fighting it, your antibody will not be positive. So what are positive? Surface antigen is positive, core antigen is pre-core antigen EAG is positive, and there will be high DNA HBV DNA levels because the virus is actively replicating. Because the immunity has not activated yet and it is not fighting the virus, there will not be any hepatitis, there will be no inflammation, and the liver function tests will be normal. Liver function tests show you that there is ongoing active inflammation within the liver. That is AST and ALT, alanine transaminase, aspartate transaminase, or the liver enzymes we look. They are normally present within the liver cell, and the liver cell, when it is damaged because of inflammation or something else, these enzymes get released into the blood. So the liver function test will be normal in immune tolerance phase. So now you see immune clearance phase. So in this, if you do a liver biopsy, there will be no hepatitis, no inflammation. Okay, I think this point is pretty clear for you. Coming to immune clearance phase. So this, when the immunity is actively trying to remove the virus from the body, you call it immune clearance phase. In this patient, what happens is HBeAg is positive, antibody is negative, DNA titers are high, elevated LFTs, liver biopsy shows chronic hepatitis with inflammation, immune clearance. So here the immunity is trying to clear. There will be antibody production, the liver will be cell-mediated immunity and humoral immunity, both will be trying to remove the virus, but still it will not be able to clear it. The body is trying to clear it, and in this phase you will have inflammation within the body. The liver enzymes will be high, DNA titers are still high. The difference from here to here is the liver enzymes. There is hepatitis here, there is no hepatitis here. Because the immunity is activated, there will be damage to liver cells. The liver function test AST and ALT will be elevated. When you do a liver biopsy, you will be finding inflammation. Okay, HBeAg is still positive because the virus is still replicating. The viral replication has not been contained, and the antibody is negative. DNA titers will be high, but not as high as immune tolerance phase because they are going unchecked. The replication is going unchecked here, but in here the virus is being contained a bit by the immunity. So this is the immune clearance phase. In this is the patient. This is the phase the patient comes with jaundice, hepatitis, all these serological tests. What is inactive carrier? In this patient, what happened is the immunity has successfully prevented the replication, not yet eliminated it totally, but has successfully prevented the replication. So the marker of replication HBe Ag is negative, the antibody HBe antibody is positive, DNA titers are low, liver function tests are normal. Because the virus is no longer replicating, it has been totally maximally suppressed. You will not have any inflammation anymore. The inflammation comes down at this point. Normal LFTs. Liver biopsy, if you do, there will be no hepatitis. But remember this: whenever there is hepatitis, there will be elevated LFTs. So when there is no hepatitis, the hepatitis come down. Liver function test also will become normal. So this is inactive carrier, and then there can be reactivation in some patients. So why does this reactivation happen? So in these patients, what happens? See, your antibody is identifying the antigen, it is binding to it, all the complement, cell-mediated immunity, everything works and is eliminating the virus. So in these patients, what happens? There will be a pre-cured mutation. The hepatitis B antigen will have a mutation, and your immunity can no longer identify the HBe antigen. One more thing, the body will, because of the mutation, the virus will not be even producing the antigen. So what happens in these patients? Hepatitis E antigen becomes negative. That doesn't mean that the virus is not replicating. It is replicating, but it is no longer producing the E antigen. So what happens? Your immunity cannot recognize the E antigen. It cannot fight the virus properly. So what happens in this patient? HBe Ag is negative because it is mutated. It is no longer producing it, and the already produced antibody is still positive. What do you think? Oh, HBe Ag is negative, antibody is positive. You think that the virus should not be replicating normally, but in these patients the virus is replicating. The DNA titers start increasing now because this arm of immunity identifying the antigen is not working. It will be recognizing surface antigen, core antigen, something else, but not this. So the virus escapes a bit from the immunity, a bit, not totally, because other arms of immunity are still working. So LFTs start elevating a bit, DNA titers start rising, but pre-core antigen is negative. That is the peculiarity in this. When this happens, you call it reactivation phase. The next phase is resolved hepatitis. What is resolved hepatitis? Okay, still no questions, right? What is resolved hepatitis? So in these patients, what happens is the virus is 99.99% eliminated from the body. Virus doesn't replicate at all in the body, and surface antigen also becomes negative, and surface antibody becomes positive. So HBs antigen becomes negative, HBs antibody is positive. Okay. So this is wrong. This is HBs antibody is positive and HBs Ag is negative. There will be undetectable HBa DNA titers and normal ALT levels. This is resolved hepatitis. So what happens? Does everybody progress through the same process, or some people progress through different process? We'll see about that right now. Okay, right. Where is it? See here. So an adult, we'll start with the adult. Okay, adult directly goes to immune clearance phase. That is the second phase. Second phase, not the immune tolerant. Adult body directly identifies the virus and goes through immune clearance phase. So from this immune clearance phase, the patient may become inactive carrier, or there will be resolution of infection. Okay, so adult directly goes to immune clearance, and from there goes to inactive carrier, or can result in loss, or can from the inactive carrier he can become totally resolved HBV infection. Okay. Children, on the other hand, directly go to immune tolerant phase. They go into this immune tolerant phase, stay there for some 10 to 20 years, and when the viral titer becomes really high and the immunity matures, when they become 20-25, at that point what happens? They go into this immune clearance phase, and from there they go into this phase and this phase. And after going into inactive carrier phase, when they have pre-core mutation, they may go into reactivation, like I spoke before. and from the reactive this is the reactive phase, and from there spontaneous loss of surface antigen is very difficult. They cannot go into spontaneous loss of surface antigen, which is resolution. Once the patient reactivates, it goes on for his life, okay, like that. So during all this ongoing hepatitis, there will be fibrosis. Active inflammation will result in deposition of fibrous tissue and will result in fibrinogen and collagen, and that will result in the development of cirrhosis, okay. From this cirrhosis, on the background of cirrhosis, some patients can develop hepatocellular carcinoma, and that is decompensation. That is a normal history of cirrhosis. So as you have seen here, adults mostly go into immune clearance phase and then to inactive carrier, and from there either reactivation phase or spontaneous loss of surface antigen and resolution. Whereas children start a step before immune tolerance phase and they go through these phases. And once anybody reaches reactivation phase, it is difficult to go lose surface antigen. It is difficult for spontaneous resolution of the infection. So we will see this. This is the serology of the chronic hepatitis B. So HBsAg will be positive for a very long period. It may come down later and may result in spontaneous resolution. Anti-HBC will be positive. Initially it will be IgM anti-HBC and later it will be IgG anti-HBC. Okay. HBeAg will be positive as till the immune clearance phase. In inactive carrier, anti-HBeAg will be positive. Okay. So see here, we will go to serological thing. So replicative phase, that is the second one, immune clearance phase or replicative phase, will call. Surface antigen is positive, core antigen is positive, but it is chronic. Because it's chronic infection, IgM will be negative and IgG will be positive. Antibody is negative, HBe antibody is negative, DNA is positive. Whereas in pre-core mutant, it's all the same, but HBeAg is negative because it is mutated and is being no longer produced, and because this is no longer being produced, the antibody will be not bound by antigen and it can be detected. Here you see the HBe antibody is positive. So coming to treatment, do you want to tell the treatment today? Yeah. So treatment algorithm. So whenever a patient comes with acute hepatitis B, you do not treat the patient. Patient will be spontaneously resolving in 95% of the patient, and your treatment will not help the patient. You only support the patient. You treat the symptom and any hemodynamic instability or whatever, you treat the symptoms. Okay. So when the patient comes to you with chronic hepatitis B, that's for more than 6 months, at this point you treat the patient. So if the patient is having ALT, liver transaminases are normal, when it will be normal? Either in an inactive carrier or immune tolerance phase. In these two patients, the inflammation will not be there. In immune tolerant phase and inactive carrier phase, the inflammation will not be there. See here. In inactive carrier, normal LFTs, no hepatitis. Immune tolerant phase, normal LFTs, no hepatitis. In these two phases, there will be no inflammation. There is no hepatitis. You need not treat the patient. You keep on checking. You keep checking the patient regularly to see if the immunity is getting activated or the virus is getting reactivated, to see if there is any hepatitis. Until there is no hepatitis, you need not treat the patient. Okay. You can ask me, sir, there is high viral replication in this patient. You can treat with the antiviral. Why are you not treating? Why we don't treat at this immune tolerant phase is because as long as you give the treatment, the virus will be suppressed. But as soon as you stop it, the virus bounces back because there is no immunity to contain the virus in these patients. And second thing, your drugs can develop resistance. The virus can develop resistance within a few years if you use the drugs. And when the patient actually goes into immune reactive phase and starts having hepatitis, there is no drug for you to treat because the virus has developed resistance for the drugs you have used. So until there is no hepatitis, we wait and keep on monitoring regularly. Okay. But as soon as the patient has cirrhosis, or as soon as the patient has hepatitis and cirrhosis, we'll start treating the patient. For example, see this. ALT is high. In these patients, there will be hepatitis. This is immune active phase, whereas hepatitis HBeAg is positive, and HBeAg negative and ALT is high. That I told you is pre-core mutant. That is due to reactivation. In these two patients, you start treatment of these patients. You do a liver biopsy, see how much of cirrhosis is there, how much of it is hepatitis, how much of it is cirrhosis, and you treat it. How do you treat? This is the treat therapy. Therapeutic option is the interferon and antiviral, nucleoside and nucleotide antiviral drugs and nucleoside analogs we give. So the details of it you need not know at this point. You can read it when you go into your final semester in MBBS. So what happened, that is about the therapeutic options. Right now we will be seeing only what are the options. The specifics we will be dealing with later. So what do you have when the patient developed complete cirrhosis? There is no point in retreatment. The virus has done the damage already. And what do you do for a patient of cirrhosis? You can transplant. You go for a liver transplant. So will the transplanted liver will also be infected by hepatitis B because the patient is already infected? Yeah, he can. And we can give the same treatment as well in the transplanted liver also. So immune prophylaxis is most important for us. We'll take 3 doses, 0, 1 and 6 at 0, 1 and 6 months. Nowadays it is being included in the vaccination schedule in the childhood itself. But all the medical professionals should be taking a vaccine as well because we are at a very high risk. So what happens? For example, you have a needle stick injury and you are not yet vaccinated. What you should be doing? So you take immunoglobulin. Immunoglobulin are already preformed antibodies against the hepatitis B antigen. On one arm we can be given immunoglobulin so that the immunoglobulin binds the virus, and another arm we can concomitantly give them hepatitis B vaccination. That is about HBV clinical presentation, treatment and prevention. Okay guys, that's it for today. We'll be talking in the next class about hepatitis C and D. Mostly I will not be coming. Abhishek will be coming for you in the next class. Thank you.